All right, thank you, everybody. I think panel 2 is mindful that they are in the always most dangerous of slots, which is the slot before lunch. But I'm excited for what they have to say, and I'm going to hand it over to Isabel Wanner.
Hello, everybody. Good morning. Yeah, everybody's tired, hungry. If you hear my stomach rumble during this, you didn't. So thank you for joining us today as we continue our conversation on how states can take advantage of the 1115 waiver to better serve our justice-impacted community. My name's Isabel Wanner. I'm from the Massachusetts Law Reform. We are the state's Poverty Law and Policy Center. And I will be moderating today's second panel, very exciting, involving the people most impacted in program design. Before we introduce today's amazing panelists and we dive into that conversation, I think it might be helpful to take a moment to understand why the 1115 waiver is such a significant opportunity for state Medicaid programs and what federal laws and guidance has brought us to this point. Kind of what Vicki touched on in our keynote and what our other panelists have spoken about, but great background for the conversation we're going to delve into. So in 2018, the Bipartisan Support Act was passed and included new provisions to promote the continuity of care for justice-involved individuals, including prohibiting states from terminating Medicaid eligibility for incarcerated youth, as well as requiring eligibility redeterminations prior to release. Importantly, the Support Act also required a national stakeholder, this is better. A national stakeholder group to convene and create a report. Some of the people who were on that group are in the room, discussing the challenges and best practices for states to help individuals being released from public institutions transition to the community with health care. In August 2021, the Medicaid Reentry Stakeholder Group met and later presented a report to Congress that identified several recommendations for designing and implementing justice-involved initiatives. One of these most profound takeaways included centering and engaging the voices of people with lived experience throughout the 1115 demonstration. That's from the initial development of a state's proposal to its final implementation at every step. In their words, centering these voices would ensure that the opportunity is both person-centered and well-tailored to the needs of this population. The Support Act also directed the U.S. Department of Health and Human Services to issue guidance on how states can design these demonstrations. In April 2023, CMS sent out guidance to state Medicaid directors on how to utilize the 1115 waiver to effectively waive the inmate exclusion and provide certain pre-release healthcare services to individuals who are incarcerated. This is a historical improvement, changing the way we can deliver healthcare to our justice-impacted community members while incarcerated. In this guidance, CMS strongly encouraged states to engage individuals with lived experience in the design and implementation of the 1115 demonstration proposals, citing recommendations from that same Medicaid reentry stakeholder group on the importance of including the voices and perspectives of justice-impacted individuals, those who are most directly affected by the demonstration in these conversations. The passage of the Support Act and the subsequent guidance from CMS underscores a critical principle. Those who are affected by carceral policies and the effects of the 1115 must have a voice in shaping them. Despite this call for involvement of people with lived experience, there remains persistent calls for better engagement of justice-impacted stakeholders. Today, we are fortunate to have with us a fantastic panel of experts to discuss why involving the perspectives of individuals with lived experience is not only necessary, but must be a fundamental component of any meaningful reform effort through the 1115. We will also be discussing the challenges that may come with this, best practices for promoting meaningful engagement of people with lived experience, and how these partnerships can maximize the potential of what the 1115 can do. At the end, there will be, again, another opportunity for questions from the audience. Without further ado, let's introduce our esteemed panelists, starting with Stacey at the end. Stacey is the founder and executive director of New Beginnings Reentry Services. Since 1982, for almost 30 years, Stacey had been in and out of prison. From her personal experiences and understanding of the system, Stacey became an abolitionist and advocate for women suffering from domestic and sexual violence. In response to the lack of resources for these women suffering from past traumas and injustices within prison, Stacey created her organization, New Beginnings Reentry Services. The mission of New Beginnings is to reduce recidivism by advocating for and providing services to women reentering local communities. With a master's degree in mental health counseling with a concentration in addictions and trauma, Stacey is a strong advocate for the women she cares for in her organization. Thank you for coming, Stacey. Maybe we should do a clap after each one because they're all great. Thank you. Next, we're happy to have Stephanie Campbell here. Stephanie is a public health practitioner, master facilitator, and educator who currently serves as the program director at HealthLeads. With a career spanning over a decade, she has held diverse roles including sexuality educator, grants manager, and adjunct faculty at Boston University's School of Public Health. Stephanie is deeply committed to using her talents and gifts in communities of color by fostering multiracial relationships and dismantling structural racism in public health and beyond. She fundamentally believes addressing structural racial inequities will lead to equitable outcomes across all systems. And you can see in her program, she provided a really great quote that I think will guide this discussion from Congresswoman Presley: "Those closest to the pain should be closest to the power." Stephanie holds a BS in Clinical Laboratory Science from Howard University and a Master's of Public Health from the University of Massachusetts. Thank you for joining us, Stephanie. Next, we have Monya Saunders, who's a community health worker with the Transitions Clinic and uses her training to provide healthcare and social service navigation for women leaving incarceration. She supports clients in connecting with both primary and specialty care appointments, including substance use and HIV, which we've touched on, providing health education specific to reentering the community, and navigating the complex health and social service system in New Haven. As part of the Health Justice Lab, Monya has delivered the Worth intervention focused on giving women leaving incarceration tools for improving their health and mental well-being. Monya's research activities now include following up with participants in the Justice Study focused on cardiovascular diseases among those recently released from incarceration. Most recently, Monya coordinated an education program focused on training New Haven residents on COVID-19 prevention and vaccination efforts. Another round of applause, please, for Monya. So the first question's for everybody. And I want to open the floor up. Can you first tell us how you got involved in the work that you are doing today and how your identity or lived experience inspires this work? Stacey, if you're comfortable with it, can we start with you?
Sure. I just want to say thank you for having me here, and thank you, Vicki, for that fabulous presentation. I've been searching for you for a long time. You're so necessary. I mean, a couple of things that I would like to touch on. And, you know, I started this work because I suffered from sexual trauma very early and a rape at 18. And I didn't know how to navigate that pain. And I went into substances. Substances took me into the criminal justice system. And there just wasn't any resources to help me. And my family didn't quite know what to do with my mental illness. It wasn't until 2008 that some of the women in prison really took me by my hand and really enlightened me on what I was doing to myself. And my brain really kind of activated, and what was I really doing to my sisters in there who had never had an opportunity to go home? And I started seeing some things different. I got involved in the law library. I started realizing I could write some revise and revokes without having a law degree, and women were going home, and then they were coming right back, and I was like, wait a minute. We can't keep doing this. There's something wrong. I must get out and create something to help my sisters. But more so, I really started seeing the effect of the criminal justice system with the disproportionate of sentencing. The guidelines were different for women of color. And I was really starting to dive into these type of cases that weren't necessarily intentional first degrees or weren't, I mean, all of us, 97% of women incarcerated have suffered from sexual and domestic violence. And, you know, we talk about the substances. We talk about the alcoholism. Women are dying in a prison and not being sent to treatment. And so I knew I had to get out and do something different. There was just one judge that really heard or saw me and humanized me in court. That's Judge Coffey. I will always honor that judge that asked me that one question: what's wrong with you? I had no idea that my brain can activate. And I just spilled out everything, and I knew in that moment, this is what accountability and responsibility really means. And let me take that accountability. And I had that interaction with him without having an attorney. And so from there, I took my sentence. I got busy with myself. I came home and I just had that tunnel vision to create a reentry program that was different than the fundamental program or halfway houses that has been in existence. And so what I mean by that is we're really trauma-informed care. We're psychodrama therapeutic processes in theater and storytelling and creative writing and a whole bunch of stuff that we do to get women prepared to come into the community, prepared to go into housing and job market. I think that we have it wrong. I think that we come out of these carceral systems after 20, 30, 40 years in these unnatural, violent, often environments, and you're supposed to go get a job. And you've been in prison since 17, you never even knew what a resume was. And so we can get into the healthcare part that is necessary to really talk about that. We really have that wrong too, from my perspective. So that's how I came home and developed New Beginnings Reentry Services, and have had no recidivism since we've been doing this work since 2016.
Thank you so much for that, Stacey, and I know you are passionate, and we will get into the healthcare side that everybody here can relate to.
Thank you.
Stephanie, if you want to go next, I know you're on the community engagement side, so whatever got you into that work and what drives you?
Yeah, hi everybody. So I think for me, professionally and personally, community engagement and partnership is how I see the world. And some of that is really just based on my identities. I think as a Black woman, you always see different perspectives and leverage that to get where you need to go. And I think the other thing that I value around community engagement is that many of the communities I work in are similar to the neighborhood I grew up in. So I have a sense of how things get going and where power truly lies. And I think it's important too today that there are oftentimes people are designing things without those most impacted truly at the table. I want to acknowledge that takes hard work and multiple steps to even rebuild that trust. So I think that's part of it. And then today, the current work I work with, we really do partner with residents in Hyde Park and Mattapan, which are neighborhoods of Boston, around ensuring that they're driving solutions to food access. And I'm happy to chat more about it, but that's just a little bit about my why.
Thank you, Stephanie. And then Monya, I know you're a community health worker in New Haven, so what got you into that and what inspired you to?
I basically got into, can you hear me? I got into this work because I, have a history of incarceration, but also seeing the effects that women face, the barriers that they face, not only women, but men as well, when returning from incarceration, and all the barriers that I think that the doctors don't get it, the social workers, maybe they don't get it. How can I make a difference as these women and men coming home from incarceration? This woman spoke of people coming home after 20 and 15 years. They don't even know what a resume is. So, I got into this line of work to assist men and women, to help them navigate and make a difference.
Absolutely. And so touching more on the subject of this and kind of connecting what drove you to this work and what we can do with this opportunity, I'd love to ask a question to Stacey first. As somebody who's leveraged your expertise from your own personal experience with the justice system to become an advocate for the community. So what supports do returning citizens and the community organizations who serve them need to participate more fully in policy and advocacy? And if you want to touch on it, in what ways do you think this 1115 waiver could help organizations like yours do so?
That's a real heavy question. You know, it's so difficult because I think that what we don't talk about enough is mental illness. And I mean, we could talk about MAT protocol, medicated assisted treatment. That has taken a whole different course within the prison. I mean, we've developed clinics in the prison. And so, you know, my work with women, we are starting to zoom in leadership academy series in the prison for the women to prepare them to come home. But when you're sitting on a Zoom and you're seeing women in there, just as us out here that are on the MAT protocol, along with their mental psych meds, they don't have really much clarity. They can't receive something because we're allowing a system to integrate primary care doctors with the MAT protocol for mental health meds. It's like a disaster. It's bizarre. And trying to navigate that to come out to try to help them. If you came into my program and saw our locked med room, massive amounts of psych meds and prescriptions in one little box that we have to now have 2 boxes, lock boxes, because we have a primary care system that has taken over mental health. Somewhere in there, I haven't been able to figure that part out. Why are we allowing our system to come out of one system into the next system and just use what was centered in a prison without redirecting our formerly incarcerated people that are being released into mental health and get diagnosed properly? I mean, it takes time for you to go into a therapist, at least 90 days, and then get an evaluation to go into psych. We seem to think MAT protocol, methadone, Suboxone, and Vivitrol doesn't work, but it's effective. It does save lives, but not so much if we don't understand it. And not so much if we're shifting from mass health to now Medicaid. And I'm not savvy on that yet, right? I'm still having a hard time with even getting credentialed or to bill for our services. But I'm not centered on that. I'm centered on the well-being and the holistic care. We could even shift from all that psych med stuff into yoga. Let's talk about some alternatives. I'm a cancer survivor as well. And so I survived a lot of stuff, but you know, we could even talk about food care. We could talk about the mess from what Leslie said about in the prison to what we even have out here. And so I don't know if I answered that question. This is so deep. I'm so passionate about this because we've had 5 women of color pass away. If we really talk about in the prison system, just trying to navigate to fill out a sick slip is so heavy now that the prison is charging $5 to fill out a sick slip. What if you don't have any money? What if you don't have any support and you're indigent? Do you not get the health care that you need? These 5 women that came out didn't have the confidence in themselves to advocate to a doctor on the needs that they need and deserve. And we're talking about one, Lisette Navarez, who came out of the prison system in stage 4 colon cancer because the prison wouldn't answer her sick slip. And as a Spanish Latino woman, she had 17 years in that prison with addictive behaviors and coming out here, and they just kind of discarded her because she is formerly incarcerated, math health recipient, and didn't really look at her as a human being and put her on oxycodone before she even thought about chemo. We could even talk about LaTanya Jones, who had this respiratory issue triggered by a psych med that gave her arrhythmia. And the doctor said, oh, you have anxiety disorder because she came from a prison, 5 years in Rikers. Me trying to mentor her out of that hospital to another hospital to say, you don't need that psych med. She went straight into cardiac arrest. Here I am trying to give her CPR, called 911. She's in a coma. She died because she had prolonged oxygen, loss of oxygen. They called it prolonged anoxia. She thought she was dealing with mental health, but she was losing oxygen in the brain. So these are the things that I'm talking about that we just don't have right. Somewhere in there, there's a disconnect as to why I said I really like Vicky's proposed idea of how we should shift. But we're so disconnected with the systems, how do we do that?
And Stacey, I know you thought maybe you wouldn't touch deeply enough into that question, but I think we can all agree the way you spoke about it is the reason why we need people with lived experience at the forefront. We're not hearing these stories. We all know about the importance of mental health and substance abuse and these chronic conditions, and we have the data, but these stories and these lived experience, things that can only come from personal lived experience, are really what will drive the narrative and will shift people to change. So thank you.
On a federal level, if I could just say that Tina Gomez also went into the federal system as an HIV woman and couldn't get her medication for 4 months. For 4 months. By the time she came out of the prison system 3 years later, she ends up in a coma. She just didn't have the proper medication, the proper care, and no one directed her, again, a shift of coming out to try to navigate, to give her primary care or any of her proper HIV medicine, hypertension medicine, all that stuff. We're just not focused on holistic care. I mean, you know, I'm not a doctor, but if you look at different doctors' positions, can we just talk about a whole body, a whole person for their mental health and health needs and not separate them? This is a whole person in front of you that we should be really focused on and get them stable enough so they can then move into considering employment and housing. That's why we need reentry homes first to get them to that level. I'm gonna be quiet.
You never have to be quiet. So kind of in that same vein of what Stacey was talking about and how we can see the importance of incorporating lived experience, a big piece of the essential services that Medicaid is offering to cover through states' 1115 waivers is hiring peer navigators and community health workers with lived experience. Monya, you are a community health worker who has been working under this model with the Transitions Clinic for several years now. So my question to you is, speaking to your experience as a community health worker for people back in the community after incarceration, how do you leverage your own personal expertise in the way you interact with patients each day? What do you think can only be learned through your own lived personal experience? And how do you think that you, as this peer, to guide somebody returning home through the healthcare system can affect the way returning folks view and are accessing their care?
That's a lot.
I know. I'll break it up.
No, listen, so the lady, I'm sorry, I don't know your name.
Stacey, it's
Stacey,
okay.
she just said the biggest piece of why people need a community health worker. People with lived experience, people who have gone through the system, you know, from medications to healthcare, like to someone to help navigate a person returning home from incarceration. Some of them max out, they're just sent on the green, nowhere to go, right? And how do they even think about a doctor's appointment? How do they think about anything when they're released with no ID? They have a criminal background, so it's hard for them to get jobs. They have to report to probation. Like how? And they have nothing. I do work with Department of Corrections with some of the discharge nurses and the discharge planners. So a lot of times I already scheduled them an appointment, so they will not be without their meds. That's one thing about having a person who's working with this population of people. If I know Sally's coming home and Sally been on a regimen of meds her whole bid for 17 years, Sally is gonna have her meds when she come home after her 30 days is gone. People need help with people who have a history of incarceration, who came out, did well, who maybe had help from someone else. Everybody doesn't have help. You know, we talk about, you know, getting to the doctors and these things and those diagnoses, but who's gonna help them navigate to primary care services? Who is gonna help them get a bus pass to get to probation? Who's gonna do the work? I work with a network of over 100 community health workers across the state. And it's always a question, who's gonna do the work? And it's the community health workers with lived experience who have that compassion and also knows what it looked like to come home and have all these things in front of you, who already suffer from mental health use. I also suffer from just a lot of trauma. And the prisons are not designed for rehabilitation with trauma. So you have to come back out into these communities, and who's gonna help you navigate? The doctors don't know what it feels like to grow up in a broken home or be molested at age 12 and have all these issues, growing up without a father, having to do this and that to feed your family and friends. I feel like with Medicaid, hire people, community health workers, to do what I do, with compassion, with knowing the history. They're not gonna trust the doctors. Like you said, they want money for you to get a visit inside, right? They're not gonna trust the doctors. They bring their own expertise to the table, but we as community health workers, we have a different level of expertise. Some of us is going back to school and we're doing great, but I think that community health workers, and it's a lot of work to do, and it's not enough of us because the Medicaid doesn't pay. So that's what I would do. One of the things I would do, there's a whole bunch of other things that go along with being, great or just being okay when you're discharged and released from incarceration. But having someone with that lived experience right there when you come home to help you navigate these things. They even give you a bus pass. But more important, they give you some hope. Hey, I've been through this. I work with doctors. I work with mental health providers. I even work with the MLP law students. So I got the whole thing. I got a lot to give to offer them, especially my care, my compassion, along with the medical team and the other folks on our team. So I think having that person with lived experience, with compassion, to help these folks come home and be great and lower the recidivism rate, and not just throw them out there with nothing. Like, they're gonna go back because they're gonna go back to their old behaviors.
And you're touching on the importance of community health workers, and you play such a pivotal role from the beginning, right, when they re-enter to the community, and kind of guiding them through that process, because it's not just one doctor's appointment, right, when you come back. It's a series of doctor's appointments, making sure they're showing up and they're getting the care they need. How do you see any changes in the people you're serving from that first initial time you meet? And what do you think your role is in kind of making them comfortable with the systems they're navigating, these really complex systems?
So I know we, at Yale University, do a lot of research. I work with a lot of great, amazing people on our team. And so some of the research studies show that folks who come home that are with a community health worker have a lesser chance. The chances of them returning back to incarceration are very, very less than someone who does not have a community health worker. So that in itself speaks volumes. Also, I think that when people go inside, they come home, and they're not the same people anymore. But their families think they're the same. Just going to visit them, but they're not the same. And they live with a lot of anxiety and a lot of questions. So I feel like just being there to support them and sharing some of my experience. I never say how much time I did because it wasn't much. But just letting them know, hey, I've been there. I've been inside. I've been in a halfway house. I've been through the domestic violence. I've been just sharing some of my experience, things I've overcome, especially with the women and some of the men. But just gaining that rapport and that trust. But like, you really was inside? I'm like, hell yeah. Some of people don't believe I've been inside, but I have. So, just giving them that hope, saying, hey, I did it before, and having the knowledge and getting the compassion and having the resources for them to be great. I hope I answered the question.
You absolutely did.
I
reference, it'd be great.
And I think, Monya, you're a pretty clear example of the importance of community health workers, and that's something that Medicaid has in the past already pointed out, the importance of peer navigators and community health workers who can draw from lived experience. Beyond that, there's still an opportunity for states to be innovative in the ways they serve the justice-impacted population when drafting their demonstration proposals. Stephanie, I'd like to hear from you with your background in models of community engagement, how we should be approaching this process. So the question would be, justice-involved individuals, perhaps more than other historically marginalized groups in Medicaid, offer a really unique perspective that comes with the experience of incarceration. This is something most, if not all, state staff and researchers tasked with designing these reentry proposals can't fully grasp without the personal experience themselves. Can you discuss the challenges that come with targeting a program to a group without the direct involvement of the group themselves?
Yes, so I have my cheat sheet here so I don't forget all my nuggets I want to tell you all. First thing that I want to say is that when you design something without those most impacted, you're very likely to design something that's not needed or people are not going to go to because they were not at the table during the creation process. The other thing that you need to be mindful of, and I say they, that's me, I have multiple hats, me as the professional included, is that you're making assumptions that you know what the root cause of the problem is. I think we've done a lot of talking today, but the root cause of many of these things are structural racism and the intersection of many of the other isms. And so it's important, it's important that we're clear on naming that because that impacts what we're designing. And too often we're designing Band-Aid solutions to the work that we're doing that keeps us in a cycle of depending on funding and running around. And no shade to the data people, I do believe in data. However, we have plenty of data. How much more data do we need to prove the cause? So I just want to say those two things. And I'll stop there.
You said a lot.
So yeah, you touched on that. Do you have
Y'all are so
any examples that come to mind of projects or things you've seen that can do this well, the community engagement side? Or if you want to speak negatively of projects that failed because of the lack of community engagement.
I'm not going to speak of them negatively because it's a lesson learned. We're so afraid to make mistakes. So even in those that didn't work well, there's opportunity for all of us to learn. And I think the other thing that I want to make sure I say is humility. Many of us walk in spaces of privilege and power and oppression simultaneously in spaces. And so you need to be aware of that when you're beginning this work. And the other thing that's important is the language that we're using, the time, the logistics. Some people don't know Zoom. I ran into this recently with a project in which we were working with community advisory board members. And because of the COVID, just moving so quickly, made an assumption that everyone can access Zoom.
Yeah.
Didn't even consider, the woman's like, I have mistrust of Zoom. I'm only gonna dial in. Here I am with a slide deck, right? And so if I didn't make space and to build a relationship with this person, I would have kept going on with my slide deck. And I was like, oh my goodness, I'm so sorry. And so I really wanna offer humility and then our jargon and then adaptability. You have to really be able to adapt to meet the needs of who you want to work with. And then the other tool I'm going to talk about, which you can find on HealthLeads website, and there are many versions of this, is the community engagement continuum. Be clear on who and why you want to partner with people. Time is precious, and people can feel when there's lack of authenticity in the relationship. If you know you are not there to power share, do not pretend to power share. Right. Be clear, I would like to consult with you on a project. I want you to inform a project, but let people know so they can decide if they want to engage with you. Holding back information is not conducive to really changing the big systems that all of us are tackling from different perspectives. And the other piece that I want to offer too is I think the sheriff on the last panel alluded to this. We need all of us in the room because each of us bring a piece to the solution of equity. And so leaving someone out does not get us any further. The reality is, in some kind of way, all of us who want to see a better world are engaged in insanity. We're doing some of the same things over and over again, and then we're still stuck with the same results. And the existing data, not new data, the existing data is proving that what we're doing currently is not the best way to continue to do the work. And then I will offer an example of something that went well and something that we learned from. So prior to my role, at HealthLeads, I worked for a state agency. And one of the things we wanted to do at the state agency was engage young people. And we are responsible for the entire state. However, we kept going through processes. I love Massachusetts. We love coalitions and advisories and work groups. No shade, but we could find a better way in that. I will say, but we had to take a step back. As a state agency, we did not have the capacity to serve young people across the entire Commonwealth. Young people do not know what a procurement process is to become an advisory member. We didn't have a way to pay them. We didn't have a way to get transportation from Berkshire County to downtown Boston. We were not the best convener, even though we really wanted to partner with them to inform our work. And so you have to recognize what your limitations are, where you sit and on who could be the best partner. So in that instance, we were able to work with our community-based orgs, provide them additional money, and be clear, like, will you liaison? Are you willing to be in relationship with us? And this is what it looks like. I think an example of one that didn't go so well is currently the work that I mentioned that HealthLeads is doing in Boston. I would say it didn't go so well. We're learning. We're in this together. Is that part of the work we have community leaders. And we are so proud of our communities. They're super dope if they're watching this or watch it later. We are proud to have them on staff at HealthLeads. But what we're running into is the cliff effect. Folks want to be engaged and being a part of designing solutions. And when I say are folks familiar with that? Benefits cliff effect? I see some head nods. In essence, they can't accept compensation from us because that will impact other services that they are receiving if they exceed a certain amount. And some of those services could be SNAP benefits. It could be services for their kids who are, may have autism. And so I think even when you mean well, you have to be careful of, as you all have mentioned, the whole person when you are trying to engage and partner with them on one aspect of their life. I think that's all my notes.
So drawing from those examples, we kind of have a real life case example happening right now in Massachusetts that I'd like to point out. So not all states are starting from square one, and several states with approved or pending waivers have already incorporated new ways to engage with stakeholders of lived experience. Here in Massachusetts, we recently announced the creation of the Community Feedback Forum for Health and Justice, a stakeholder advisory council made up of individuals with lived experience of incarceration, their loved ones, as well as organizations who serve justice-impacted individuals. This group is tasked with advising the Executive Office of Health and Human Services on the implementation of pre-release coverage for eligible incarcerated individuals, and they've said that justice-involved members will be compensated for their time and expertise. My question for everybody is kind of just gauging initial reactions to that. What are your initial reactions to the Community Feedback Forum and what it can accomplish? What advice can you give to make sure that this advisory group is effectively leveraging the importance of lived experience? And Stacey, if you're ready, I can start with you.
I don't know if I'm ready to dive in on that one. I'm so grateful for you two sisters. I mean, all of that. Like, this is the importance of to have these type of panels because there's so much to get out, and I'm just so grateful for you two. I just needed to say that because my mind is always trying to figure out how to get out this information. It's a lot. I kind of just want to allude, if I may, to what Sheriff Katusian kind of alluded to, if I may, because you kind of brought that up, that when we talk about racial disparities, we know the higher population of incarceration comes from Black and brown communities because the data is just so much data. Well, I don't even know why we keep doing data, but what is really happening from my understanding, and I think that you and I have discussed this, Isabel, I continuously I'm baffled. I'm trying to figure out how we have this type of system when Sheriff Katusian spoke about electronic health records, right? To have that type of system as an organization, that's a lot of money. It's almost like $40,000, and you kind of can't have that unless you're partnered with the Department of Public Health, and if you're partnered with them, then you have to be COF certified, which is another $30,000, $40,000. as an organization that are dealing with Medicaid Mass Health as a provider service. That is a difficult challenge. And I suspect I ran into something, and I have to put it out there. I'm an abolitionist. I don't believe in prisons. And so I lived in them. I want to say, like, if you had an experience, just go home in your bathroom and close the door and try to see if you could do 8 or 10 hours in there, because that's the size of a cell. I just want to say that, because when you're dealing with a system that has no oversight, such as a sheriff's department that has partnered with these healthcare systems, that monies are shifted out of a DOC prison to a sheriff's department for these type of provided services or monies. Middlesex and Worcester County has had that partnership through the Commission of Probation. Now, that's baffling to me, and I still don't understand how to even convey this, because you left out a whole Suffolk County population. And the Suffolk County population is the highest sentencing structure for incarceration. The highest population of incarceration comes from Black and brown communities. We know that from data. And so when you're going into a prison system and trying to navigate out 90 days toward your release, Massachusetts law says you have to have health insurance. So they give them health insurance. But by the time you come to Suffolk County, you only have primary care. And then we have this new system that says you can't upgrade your health insurance until open enrollment in October. So if you came out in May, we're kind of shit out of luck without having any mental health services. So as a provider, we have to jump on there and do what they call out-of-network authorization. And I'm like, what is that? And then you drop in this whole WellSense. You come from WellPath of a prison system, don't give you proper health care, to a WellSense new insurance provider. I don't even know what that means, because when you shift this past October, we said, okay, ladies, we have 7 women in the house. Let's get you proper mental health care so you can go to these community centers that we've partnered with to get some mental health services. We had to shift their mass health, and it took them out of their healthcare center to send them over to Arlington somewhere. Because this place won't take WellSense, but shifting them to Tufts, they could take it over there. So it still brings us out of our community, out of our realm, and you're dealing with someone who just had an abnormal pap smear in the prison, and they don't even know what that is. And now you started medication, or you've had a primary care doctor, and as a provider, we're like, well, we're trying to give you some, I have a mental health degree, but I didn't choose to be a licensed mental health practitioner, so I can't give you mental health. I could give it to you over here, but now you gotta go to Arlington. Now, I told you we deal with state and federal women who have done 10, 20, 30, 40 years. And often, these are cases that are either arson, second degree, first degree murder. If we fought through participatory defense to get them down to a second degree to get them out on parole, well, how about they're scared to go on a bus? How about they're scared to come back into the community and take the ride, because there's victims' families out there that not only want to kill them, but they want to kill me too. So here I am, taking them on a bus, saying we're going to get back into the community, and we're going to learn accountability, and we're going to learn how to be responsible to navigate through these systems. It is a lot. And it's a lot of work when I'm sitting in an office asking a doctor, what are you giving her that prescription for when she came in here for an abnormal pap smear? Can she get a gynecologist? We didn't talk about these type of heavy medicines. You just want to put them on medicines. You only seen them for 5 minutes. This is what we're talking about. I don't even know if I answered that. I just had to get that out. Because this is part of the work that we don't talk about.
That's right.
We don't talk about that enough. And I do it every day.
Me too, yeah.
It's exhausting work. And we should be providing them the right services. It's rewarding for me when I see a woman say, oh my God. Now, how did I get to where I'm at? First, because, I don't know, I had an abnormal pap smear when I was in prison. I didn't know what that meant, but when I came out and went to college, I had a really good professor who said, let's do a genogram. Okay, what is that? It brought me into understanding all of the health issues in my family. On my father's side, slew of cancer. On my mother's side, heart attacks and strokes. I'm like, oh, wow. It took me 5 gynecologists just for me to get a biopsy. 5 gynecologists. And I could have gave up. I would be dead today if I gave up. And cancer, endometrial cancer, was right there because the prison had an abnormal pap smear, but the doctors will say, well, it costs too much, or it's too painful, or you don't need one because you don't have an abnormal pap smear. And I'm like, but I did have one in 1998. Cancer had been riddling in me for quite a while. And so twice cancer. These are the things that we need to start talking about, that women and men just don't know. And it's harder for men because a man is like, no, I'm not getting a colonoscopy. I don't want anything. No, I'm not going to have these type of prostates because nothing is going up in my penis. And I'm like, wait a minute. You're like 40. And they'll tell you to not do that until you're 50. This is a lot. And so, again, I have to give these women thank you for finding these 2 sisters because this is some heavy stuff to talk about. And this is just my line of work of what I do to get women aligned and men aligned because we do a lot of participatory defense organizing. We know that I have 7 men that I mentor that are wrongfully convicted who never had any health care. And so it's a lot. It's a lot to dismantle and it's a lot to disrupt. I just want to say that one more time. It's a lot to dismantle and it's a lot to disrupt.
Thank you, Stacey. You said it perfectly, and I think the way you speak about things, even though this is a very diverse room of healthcare providers, and we've got legal advocates, and we all know about these general consensus of the needs in reentry healthcare, but the way you speak to these things really points out the need for a seat at the table and really having people with lived experience and the ways that we can't touch upon without experiencing it ourselves. So I want to make time for audience questions, so I just want to kind of round off with our last question, and maybe Monya, I'll start with you. Just broadly, what does meaningful engagement of people with lived experience look like to you? When we're talking about a seat at the table, is it just representation, or how do we kind of elevate that to a level that gives you power and that amplifies the voices of people without it being merely for empty words or empty promises?
Yeah, so I honestly feel like having a seat at the table with lived experience is meaningful, would be effective for people because you're their voice. Having a seat at the table for this population of people is that you understand and know the barriers. You see the problems. You see the cracks in the system. You said a lot, and I have to agree with her. There's so much work to do. But I honestly feel, and I know I've said it before, that people with lived experience are the best folks to advocate for these people. Like the one Sharon said, people, the guys, they don't want colonoscopies, they don't want stuff in their butts. That's guys, it's prison. They have some trauma in that area as well. So they don't want colonoscopy. But somebody like me who's well educated, I could convince Tom to get that one. I feel like they get it from me. Am I a doctor? Absolutely not. But I work with a team of doctors with amazing people. And so I'm educated and I can, and hence educate them. Boy, you better get that daggone colonoscopy. Didn't you say your father died from cancer? And that might sound funny or weird, but I know the approach is, and to get that, but the BIG for me is, I always use the word great because I want everybody to be great. Yeah. And I know they can be great, but there's a lot of cracks in the system. I want these guys and women to come home with ID. Probation, like, oh, they're gonna lock me back up if I don't get a job. But he doesn't have ID. How is this possible? How? You have an ID. We know you have an ID when you're on the compound. Am I right or wrong? So to come back out in the communities with no ID, with all these demands, I can't get anything. I don't have an ID. I'm the voice. I need to have the seat at the table. I'm at the state's office. I'm fighting for policy change. I'm fighting for me, the team, not just me alone, but I work with hundreds of community health workers and law students. So what's in his, I'm not just doing the work, but I'm trying to fight for change with policy change. So again, I feel like men and women with the passion, not just the experience, but the passion.
Yeah.
Gotta have that passion, or
Yeah.
else nothing is gonna work. Have the knowledge and work with great people who know things that I don't. I don't know it all, but that piece I do have is, that experience.
Yeah.
The going through trauma, living with the nightmares of being abused, living with the nightmares of being, gang raped and molested.
Yeah.
These are what the women are going through, and I'm learning it's not only women, it's the men. How am I gonna be great? How am I gonna move forward? I'm too high from the medications to even know what's going on. Tell them to take this medication down, Monya. Call the doctor.
Yeah.
I can't focus. I'm sleeping too much.
Yeah.
The medications, get the regimen right. You know what I mean? There's a lot of pieces to this puzzle, but I feel like we're not gonna give up. We're gonna figure it out together.
Yeah.
And people with lived experience is where it begins.
The only other piece I would add, thank you both, is compensation. I think, yes, have us, I struggle with at the table, build a new table so that the power dynamics are real. And I literally would say compensation. I think it's very important to make sure folks with lived experience is equitably compensated. And then lastly, consider who and why you want them at the table. I think that's the best advice I have.
I like that. Build your new table.
I don't want to keep us from lunch with all the tables because I'm hungry.
And then Stacey, maybe briefly, if you have thoughts on what effective community engagement looks like, and then we'll take some minutes for questions from the audience.
I think it would be, I've been in my community engagement office really, I'm looking at the floor because we're really looking at trying to create an ecosystem. I mean, there's a lot of us formerly incarcerated on the ground doing work. I think Leslie alluded to Justice for Housing. We are Better Together Foundation. We have Families for Justice's Healing. We have the National Council for Incarcerated and Formerly Incarcerated Women and Girls. We have Transformation Prison Project. We have Life Beyond Bar. I mean, we have a whole bunch of us out here doing the work. If we can bring it together along with, Leslie started this some years back with, I think, Boston City Hospital. She had a couple of doctors that really was trying to kind of build some camaraderie with us. And, I mean, it would be explosive. Funding is a whole different topic because often the state are looking at us as formerly incarcerated and not victim-centered. There are victims out there, but no one ever looks at us as victims. So we have to start shifting the trajectory or our ideology of how we are thinking. Crime and punishment has got to be done with by now. And we need to start shifting toward transform harm and restorative justice models. And what would that look like? Bringing ecosystem, just building a whole ecosystem based on that model, transformative? Man, and that's what I'm doing little by little in my office. I'm like putting little notes down and I'm looking at it. Building a community. That's community of healthcare, mental health, formerly incarcerated people, students, young people. Come on. We can really change how we're viewing and dismantling a system. We're the lowest population in the country of incarceration. Framingham has 212 women, last I've heard. I visited, if I could just say, I just had an opportunity to be in Shirley Medium with 70 men who put on a fabulous Black History Month. And I mean, I was in there crying, because I'm like, I'm sure you all aren't all in the same unit. How did they do that? They had speakers, they had dancers, they had rappers, they had an imam that they really admired, and the imam got up and said his spiel when you seen black, white, Chinese, Spanish, all of them stood behind him, and I was like, wait a minute. You guys aren't up here fighting like they're letting us believe? You guys are really forming camaraderie in here and healing, togetherness. I've never seen Muslim in that sense of togetherness. It was so moving that they had to kick me out. They're like, okay, it's time. First of all, I was like, I was in my element because I was in a gym in a prison that I grew up in. And to be in there to see these fabulous men that most of them were lifers. And I'm like, it's kind of time for y'all to come home. And then even hearing that they don't have any healthcare providers. They don't have anybody to talk to release that in-depth trauma. We have a lot of advocates out here. We know what just happened with the lower or the rate of the age of to 21 that you can't incarcerate to life. And so a lot of our population are coming home. How do we want them to be our neighbor if we're not providing these type of particular services that they need and deserve? And so I'm going to just end it there. Really just creating this ecosystem would be just fabulous.
Thank you. And I think that's a really great question to leave this part of the discussion. How do you want them to be our neighbor? While we talk about it kind of in the abstract of people with lived experience, they are our neighbors and family members and friends, and we really need to consider them in the whole person-centered of care and not just the ways we've been looking at through data or through different lenses that don't kind of encapsulate the full being. So hopefully we have a little bit of time, I see, for questions. So if we have any questions in the audience, maybe I'll start with Leslie up front.
Yeah, I have a question. Hi. Actually, it's for you. So, you know, when you walk into a prison and you have 15 years and your child just got put in foster care, your family's separated, you just lost your home, your job, and you're trying to process all of this. Yet, you are not unable to, because once you express your feelings, you are put into solitary confinement. The reaction from the DOC is punitive. They take that as she might try to hurt herself. She's depressed. She's going through this. They don't want to be sued. So they put you in solitary confinement on suicide watch when you're not suicidal. And so there's a lot of unmet trauma because you can't release that. And so when you come home, all of that is all balled up inside. So what we see is, I just had 2 men come home, put into our reentry house, who were schizophrenic and suicidal. No one from the DOC, probation, parole, told us that they had these issues. They had to be taken out the house 5 times by the best team. But every time they were taken out, they were released the same day. And we were telling them they're suicidal. And so, you know, first of all, the DOC gets $800 million a year to house and you know, provide services. So how do you trust that if they're able to bill, because they couldn't do the job with $800 million. So how are you going to trust that if they're able to bill, that these services are going to be provided? Because they haven't proven that to date. And so working with a community organization, that's why when people are incarcerated, they don't trust, right? They don't trust the DOC, but they trust us. And so how do you provide the oversight when we were once formerly incarcerated, and how are they gonna respect us, right? Because they've never shown a respect for us before, right? As experts, as we walk in that door as experts, how are they gonna show respect and also hold themselves accountable? Where is the oversight gonna come from? That's my question.
I mean, I think like you said, it's hard. You can't guarantee that there will be trust there, and the onus is on these larger entities and the Department of Corrections, and so the onus is on them to build the relationship with people with lived experience and being not only including them in the conversation but being led by them. And when someone like you raises a point, and it doesn't go heard, and I think we have really great examples today of like Sheriff Katusian and David Ryan, of people who are trying to bridge that gap from systems that are traditionally exclusive, especially of people with lived experience. And I think we're growing to a point where we're more mindful of the power imbalances and how to truly, genuinely make meaningful change. I personally, I don't know if anybody here has thoughts on the element of trust in this relationship. It's a really hard topic, I think, like you raise. And we're a room full of a lot of different perspectives with a common goal, but obviously there's going to be a lot of different perspectives and ways to get there. This panel really... Go ahead.
If I could just say that in our home, in our residential program, me as a licensed clinician, I have the prison send a psych social. When you look at someone psychosocial, our liability insurance won't allow us to take someone that is suicidal in adulthood. In childhood, it's different. But we don't, if we can't accept them, we don't drop the ball there. We've partnered with like organizations like Odessa Health.
I understand, but you probably have HIPAA policies, right?
Well, I mean, HIPAA is a little different, but the point I'm making,
gets
to have
covered.
someone come in and have them keep going to best, if you had them put a policy in your program that says, you know, you gotta look at the psychosocial. What are they dealing with? What is their history? What is their medical history? What's their psych history? Right? And then you could redirect them to the partnerships that you develop. That's all, I just wanted to offer that. That's what we do.
Right, I understand that.
And then no man's left behind, because
There's also HIPAA laws that prevent some organizations from
Well,
so that's another issue that, you know, this is, like you said, there has to be a process put in place. And everybody has to have access or have the resources, right, to be able to look at, otherwise I would look at, but I can't because I'm not HIPAA, you know, and so I have to trust that they're gonna relay that information.
There's a question there. See, we got this red thing flashing.
This has to be our last question.
Sorry, I know lunch is imminent. I think that I have kind of just a similar question from what Leslie was just saying. I'm Allegra, I'm the Chief of Healthcare Equity at the Rhode Island Department of Health. I do Olmstead coordination as well. And something that we talk about a lot in Rhode Island, there's probably some Rhode Islanders maybe here, is this idea of, you know, we were so excited and so passionate about how much Medicaid and other funding systems have kind of invested in equity and are finally seeing something that we've been talking about for a long time. But then what we're seeing is that the money that's being invested, for instance, from places like Medicaid, is being invested into our clinical partners. And it's putting the onus on them, in their minds, to do this equity work that's been being done at the community level for years. And that means that instead of supporting the people who actually know how to do the work best, we end up with people that are not designed to do this work, recreating it and doing it and not doing it well.
Being effective.
And so how, for all the people who know more about policy than me and Medicaid policy specifically, can we push this opportunity with the waiver to make sure that they're actually able to invest in things like community-based organizations in a serious way, and definitely not in the way that it's going through healthcare, because that doesn't always work.
Thank you, Larry. Did anybody want to comment on that?
I hate to be the one to keep
No, do
talking,
it,
but
do it.
I don't have kind words.
I just want to say, I mean, there was
Because
a
it is what
time
it
that
is.
we had Health and Human Services to deal with the prison industry when they came out, which was a lot of programming. We had correctional, what was it? Correctional Recovery Academy. We had a lot of psych services. That was, of course, 15 years ago when I've been home 15 years. But then in the past, right before COVID, or maybe 7 years, it shifted into public safety, right? A lot of money going into the Executive Office of Public Safety to oversee healthcare services. That if we're in a prison, there must be some health disparities and mental health stuff happening. We know that from data again. Substance abuse, alcoholism is prevalent. Trauma prevalent in the prison system. But yet we shifted into policing instead of Health and Human Services to deal with the holistic care of the body, of the person.
I don't have a real answer to your question, but I have a wish that I think it's an opportunity in which you're raising, which is very common, right? Oftentimes, policies come in place, you have clinical partners who are positioned in a unique way against CBOs who've been doing this work. So I think you have made aware another opportunity as we're talking about the waiver to really leverage. If I could change something, I think it would really be requiring those clinical partners who may be able to get access to, as the woman over here said, different files on people's mental health backgrounds, but they must be in true partnership with you all. And true partnership for this little radical person is like 80-20, so you get most of the money.
I totally agree with her. In a perfect world, everybody would have a seat at the table, and we always fight for policy and changes to be better for our population of people we serve. So again, it goes back to policies.
And making sure those who've been doing the work get the resources. I mean, that's ultimately what
Who's been doing
equitable community engagement means. It's not that we don't have the solutions, we don't have access to the resources. And I'm done.
Let's give a round of applause.